All 12 jurors and the 5 alternates are present. Good afternoon to everybody again. Dr. Kamangar, good afternoon again, sir.
Good afternoon.
You acknowledge you are still under oath and still sworn to tell the truth?
Yes, sir.
Thank you. This would be a resumption of direct examination by the people. Mr. Walgren.
Thank you, Your Honor.
You're welcome.
Doctor, I wanted to ask you about the significance of the timing of the 911 call that you have testified about, regarding an extreme and unconscionable violation of the standard of care. I want you to assume that Dr. Murray found Mr. Jackson at about noon in the condition he described in the interview statement you've read. And let's assume then he was found at noon, and you've also read the interview statement where Dr. Murray called Michael Amir Williams and indicated he did not want to ask Michael Amir Williams to call 911. Do you know to what I'm referring?
Correct.
So I want you to assume that he finds Michael Jackson, let's just say, for the sake of argument, at noon, and makes that call to Michael Amir Williams at 12:12 p.m. As someone in critical care specialist and knowledge in this field, what is the significance of that 12 minutes from the time of finding Mr. Jackson to calling Michael Amir Williams when he could have obviously instead called 911?
I think the greatest significance in this scenario, having cared for many patients in this similar situations, is really the lack of blood flow to the vital organs. And the most vital organ when somebody is in cardiac arrest or cardiopulmonary arrest is the brain. And the brain is very sensitive to that lack of blood flow. And the longer the brain is without adequate perfusion, adequate blood, and with it oxygen, the more likely that individual is to have a deleterious effect from the lack of oxygen. Now, that is variable in different individuals, and some individuals are more susceptible to the lack of oxygen than others. But certainly beyond a period of 4 to 5 minutes is really when brain cells begin to die, when there is inadequate perfusion to the brain. And these are really kind of the golden minutes that is essential to really maintain that blood flow until a more definitive help arrives and there is restoration of circulation. So it is very critical, and the most immediate jeopardy is the higher part of the brain called the cerebral hemispheres. Now, I'm not a neurologist, but this is something we see all the time, is patients that are found, within a shorter period of time. Sometimes it's the higher part of the brain, the hemispheres, that make us who we are, allow us to coordinate motions, allow us to speak, allow us to have feelings. That is the part of the brain that is usually affected first. And sometimes people initially that are in that state, they're in what we call a comatose state, where they're unresponsive, and then over time, if their body survives, if they survive that initial period, usually 3 to 4 weeks, then at times they progress to this state of persistent vegetative state that we also unfortunately see, and that is obviously devastating in its own right. But certainly if there's even longer periods of lack of blood flow to the brain, the more vital part of the brain that is responsible for basic bodily functions like maintaining a blood pressure or breathing, the brain stem gets affected, and then that is incompatible with life. So certainly the longer there is lack of perfusion to the brain, the more significant the sequelae, meaning the worse the outcome. And certainly time is really of the essence.
Okay, and you said specifically beyond 4 to 5 minutes, the brain cells start to die. Is that accurate?
Right. There is variability. We see this all the time with different individuals. Not everybody fits the same mold, but certainly beyond 5 minutes, I think it can be quite devastating if there is really no circulation or effective CPR during beyond that 5-minute period.
And in a way, that's almost the best case scenario. That's assuming you don't die.
That's correct. That's correct. And again, that's the variability, that every person is different. And that is really kind of the art of medicine. There's not, everybody fits a certain rule. Some people are, you're right, more sensitive to that and can die earlier. Absolutely.
And then going then from 12 o'clock to when Dr. Murray calls Michael Amir at 12:12, I want you to assume, and if you know from the records you reviewed, that 911 was called at 12:20. So now from the assumed time that Dr. Murray found the patient, it's 20 minutes till the time that 911 is called. What is the significance of that?
Well, that just compounds the underlying effect of lack of adequate circulation and adequate oxygen to the brain, or the anoxia, lack of oxygen again to the brain, that is really, really critical. And I think at that point it really becomes irreversible. I mean, you reach a point where even if you are otherwise healthy and young, it becomes impossible.
Thank you. Now, you also, in your report, document and conclude that Murray deceived the paramedics by withholding key information about the propofol, and go on to say he also deceived the medical staff at UCLA about the propofol. You describe that deception as unconscionable and extreme violation of the standard of care. Can you explain your reasoning and your findings in that regard?
It is, essential to provide every element of a patient's history, and particularly in this situation, to really exclude the use of probably, most definitely the strongest agent, the strongest sedative here, was really unconscionable. By providing all the history, the medical personnel, whether it's the paramedic and later the emergency staff, are able to really focus in on the problem as opposed to trying to eliminate others. It really allows them, it provides them with critical information that is there. And when you have that information and you're not giving it, you are really doing wrong by really one of the basic principles of medicine, of just first putting your patient first.
Now, as a board-certified expert in sleep medicine, did you also then analyze the facts as you understand them to be in this case from a sleep medicine perspective?
That's correct, I did.
And you discuss initially that no indication that Dr. Murray performed an appropriate diagnostic evaluation of Mr. Jackson's insomnia. What is a diagnostic evaluation of insomnia?
I think the most key part is a detailed history. Insomnia is a problem that very often is secondary. It's comorbid. It's associated with other problems. Namely, it's associated with underlying medical disease, underlying psychiatric or psychological disease, substance abuse or medication history, as well as certain sleep disorders in and of themselves can cause insomnia. So the most important part of evaluating a patient with insomnia is to get a detailed history, to really have a comprehensive assessment of any underlying medical problems, to potentially rule out any medications or any substance abuse problems that could be causing. These could be very simple as just caffeine intake or stimulants. Patients that are on methamphetamines, for example, or for sometimes treatment of underlying disorders. It is imperative to first rule out these secondary causes because they are so prevalent, and insomnia is a very prevalent condition. So our duty is always first to exclude secondary causes before we perhaps label someone as having primary insomnia, which is when you've excluded all the secondary causes. like I mentioned, the medical problem, psychiatric problem, medications, and sleep disorders that can result in the insomnia itself.
Can you educate us a bit on insomnia? The different types of insomnia? You mentioned primary insomnia.
Right. I mean, it's
No, please, if you could just give us kind of an overview,
Sure.
A general understanding of insomnia.
Sure. Insomnia is really defined as of difficulty with sleep or unrestful sleep over a period of 4 weeks or longer. That is further broken down into patterns of insomnia, which are just variations that can occur with different types of insomnia, which are people that have problems with what we call sleep onset insomnia, where they just don't fall asleep. The problem is actually falling asleep. So they have a long time between when they go to bed and when they fall asleep. There's sleep problems with sleep maintenance insomnia, people that just go to sleep but keep waking up, so they have multiple awakenings and cannot maintain sleep. There are people that wake up early from sleep and then cannot go back to sleep. We see that sometimes in elderly individuals, more of a circadian problem, because their circadian clock, the part of their brain that tells them to wake up, they're the early risers, we call. So there are these patterns, but then once we go down and we kind of dissect insomnia, really we break it down into secondary insomnia, which is due to underlying conditions that we just talked about. And once we've ruled out those underlying conditions or medications or even environmental factors, someone is just sleeping in a room that's always lit. We talked about the intensive care unit is not lacking the proper kind of environmental disposition for good sleep. So environmental factors, medications, medical illnesses, sleep disorders, psychiatric problems. Once you've ruled all those out, then we usually refer to it as primary insomnia. So as you can imagine, the history, medication use, psychiatric history is pivotal. I mean, a lot of time is spent just to figure that out.
And then in pursuit of this complete diagnostic evaluation, I assume this ties in with the medical records again, that this would all be documented and charted and for future use?
Correct. I mean, that is part of the initial evaluation where you do an initial assessment or history and physical that's really geared towards the underlying problem, and it would really go over not only the positives, the pertinent positive, the conditions that patient may have that may be resulting in the insomnia, but also pertinent negatives, things that you've excluded as well that are important to note.
Now, you include in the diagnostic evaluation that you need to take a detailed sleep history. What is that?
Yeah, it's quite basic. It is asking the patients about just patterns of sleep. When do they go to sleep? When do they go to bed? Versus what time do they fall asleep? How many times in the middle of the night do you wake up? What time do you wake up in the morning? What medications and drugs that may be involved are also as part of that history that we talked about. A sleep diary or a sleep log where we give them patients a log where they actually fill out a week-by-week kind of night-by-night log of when they go to bed. Once they go to bed, how long it takes them to fall asleep. When do they have their awakenings? When do they wake up? Is very clear. It allows us to kind of look at this trend and say, well, this is the problem. This is what's going on. It really helps in the diagnosis by following that trend. Whether there's any extraneous circumstances, acute stressors that may be involved here. I didn't sleep well last night. I knew I was coming here. That is kind of an extraneous situation. That is part of insomnia. I mean, that these are important things that need to be asked. Some stressors can be there chronically. Patients have chronic anxiety disorders. A good psychiatric history is really pivotal. There's a very clear link between depression and insomnia. they can really feed on each other, and one can make the other worse. So that is essential. Doing a good sleep history to see if there's other sleep-related disorders. We mentioned before sleep apnea. Doing a good sleep history and doing a scoring system to see how much excessive daytime sleepiness these patients have, to see if you need to do any further testing, like a sleep study. Now, we don't necessarily have to do sleep studies. They don't have to be done on these patients. But if there is a suggestion of obstructive sleep apnea, for example, or central apnea, or limb movement disorders, or where patients have inadvertent movement of their extremities that causes arousals, that requires a sleep study, for example. So it's very important, and all of this is part of that history that I was alluding to earlier.
Thank you. You also talk about the need to do a detailed, as part of this initial diagnostic evaluation, the need to do a detailed pharmaceutical history.
That's correct.
And what does that mean?
Pharmaceutical history is medications, and these can be prescribed medications or just things that you may not even know you're taking. I mean, sometimes I've had patients that just we're taking these pills for migraines, and pills for migraines often contain caffeine, Excedrin, migraine, for example, and they didn't realize that their migraine pill was what was causing them to not sleep. So it's really important to rule out and exclude medications both over the counter, but as well as prescribed, but also illicit drugs and things like methamphetamines, or patients that have substance abuse issues where they may be withdrawing from something, and that is resulting in their insomnia is also important. So I think a very detailed pharmaceutical history, including illicit substances, needs to be asked about and ruled out.
You also mentioned a detailed physical examination, again, as part of this initial diagnostic evaluation for insomnia. What would that detailed physical examination need to include?
Right. Virtually any medical condition, certainly chronic medical diseases, can lead to insomnia. I mean, these are things that we all know about, conditions like asthma. Under my own specialty, patients with asthma have nocturnal awakenings when they have difficulty breathing. They have wheezing at night. So if you don't control their asthma, you don't control their insomnia. So there are a whole host of medical problems that sometimes just a physical exam, examining the patient, can help you at least have a clue and detect and be able to move on further with further tests and confirm. Congestive heart failure, patients with bad heart failure, they can't sleep flat at nights, and their insomnia is because they can't breathe at nights. Patients with diabetes, whose diabetes is very poorly controlled, they urinate multiple times at night. That is the problem. Patients with bladder problems, or just enlargement of the prostate that we just see as part of aging in men, can cause frequency, meaning urinating multiple times, and that could be the cause. So the history, the physical exam really kind of adds to the history and tries to pick up potentially some conditions that may be obvious. Thyroid disorders like low and high thyroid conditions, hypo and hyperthyroidism, sometimes you can get a clue to that as the exam that you do and feeling the thyroid. But certainly a lot of what we find on physical exam needs to further be confirmed by testing, like blood testing and other testing to confirm.
And you did mention in your report the requirement or the need to do laboratory testing or blood testing to kind of rule out some of these other factors.
Right. Basic, this is for the initial evaluation, just basic testing, just ruling out basic conditions, making sure their kidney function is normal, making sure that they don't have diabetes, checking for the blood test we use to check for control of blood sugars over an extended period of time, called the hemoglobin A1C, can sometimes be reasonable. Certain conditions such as restless leg syndrome, for example, can be associated with low iron stores, so we check ferritin levels in these patients. So there are a number of these tests that are routine that can at least clue us into these reversible processes where the treatment is really treating the underlying condition first and then seeing if the insomnia gets better.
And of course, appropriate blood work or laboratory work would also reveal narcotics or things that are in the blood as well, correct?
That is if you choose to look for that. I mean, normally I think you do a good history and you ask your patients, the hope is that they would divulge that information to you.
And if you had, as a doctor, if you had suspicions or knowledge and you felt the patient was not being candid, you could do that blood work or simply refuse treatment, correct?
Absolutely. I would argue that, my perspective is I would not want to do a test that my patient is not aware of. Sometimes I have to admit that people do urine tests on patients for basic drug screens when they come in very sick into the emergency room. But in general, for someone like this, I personally would not advocate doing a test without my patients knowing about, and if I feel that the patient isn't divulging that information, then absolutely, I would not want to move further and treat them medically without, knowing that they are not perhaps sharing all the information that needs to be shared, therefore impeding my ability to really help them and implement the appropriate therapy.
And so if you felt, again, to be clear, if you felt you were not getting the information desired from the patient, you could simply refuse to treat that patient.
Absolutely.
Now, in doing this diagnostic evaluation, you mentioned if you do find some underlying condition, either a medical condition or psychiatric or substance abuse, the next step then would be to treat that underlying condition with the appropriate therapy as you proceed through this insomnia care. Is that accurate?
That's correct.
And so what is the aim there as far as the therapy?
Well, the therapy is really to deal with the underlying problem. I mentioned some examples of medical conditions. I mean, if you treat the underlying medical problem, and if it's that problem that is resulting in the insomnia, I used asthma as an example. Patients waking up in the middle of the night because they're wheezing. You gain better control of their asthma, their insomnia is going to get better. If you treat their underlying, let's say they have anxiety and depression, you treat their anxiety disorder and their depression with antidepressants, for example, that can control their insomnia. So these are treatments really that are geared towards secondary insomnia, where the problem is due to an underlying medical, psychiatric, etc. History. And the other thing is if it's an environmental cause, they're just sleeping in the wrong place. They got their kids sleeping in the bed with them, and they're kicking them all night. I mean, of course, you have to change the environment. So it's important to be cognizant of those factors as well.
Now, in this first phase of the appropriate treatment for insomnia, the need to conduct a diagnostic evaluation, you found that Dr. Murray acted with an extreme deviation or gross negligence regarding the standard of care.
Yeah, again, it's imperative when you're starting treatment on somebody, and this goes for any condition, is to start off with a detailed history. And to treat insomnia really without ruling out secondary causes, to really saying, well, what is the root of the problem, and dealing with the root problem is key before actually starting to just medicate patients.
And you noted in your analysis that Dr. Murray admitted knowledge that Michael Jackson was seeing other doctors and seeing IV sites on his body.
Right.
Okay. Yet he did nothing to ascertain the other care.
Right. I think it's really key when you are suspicious of that, and obviously I think what you're alluding to is being suspicion about someone having a substance abuse problem. It is really important to really hone in on that and try to get more history. And if the patient doesn't provide that history, it is imperative on the physician to try to get as much possible. And then finally, we mentioned earlier, if they're not really, able to do that or willing to do that, it is to refuse care in terms of just providing with pharmacological medication therapy.
And you described that need to either make independent inquiries about the care by other doctors or simply to refuse treatment. To not take one of those options is an ethical failure on the part of Dr. Murray.
Correct. I mean, this is really, again, patients come first, and it's our duty to try to find out as much as we can, to make every effort to try to get as much history. If a patient comes in and we're not able to talk to them, and we know they were hospitalized somewhere else, what we first do is try to get every single record from wherever they were hospitalized, to get every detail. And I think it is really to ignore the patient's past and their history that is so pertinent to what you're doing and how you're managing them is really unethical.
So in your analysis then, by bypassing the diagnostic evaluation and bypassing whether there's some secondary cause of the insomnia and going straight to the infusion of these dangerous sedatives, was that part of your conclusion that this was an extreme and unethical violation of the standard of care?
That's correct. That's correct. Because obviously there was a great potential here for there to have been these reversible causes, these secondary causes to the insomnia. I'm still not saying that the management, even if this was a primary insomnia, was appropriate, but I'm saying that there were clearly signs that there were secondary causes, whether it was substance abuse issues or anxiety issues, underlying psychiatric issues, psychological problems. Those issues needed to be addressed first and foremost with really great care and attention, and not just proceeding to medical management with drugs.
And once a determination was made through this diagnostic evaluation that there was either, let's say, a secondary insomnia or a primary insomnia, you've indicated there are two, well, it's a multifaceted approach in treatment that can involve both pharmacological approach as well as a behavioral approach. Can you explain what you mean by that?
Right. Very often, obviously, once you've done your initial workup, one of the most effective ways to treat insomnia, both primary as well as the secondary causes of insomnia, is just what we call cognitive behavioral therapy. And it really incorporates many factors. Patients that have primary insomnia, particularly over a prolonged period of time, have this fear of going to sleep because they just feel like they associate the bed and that situation with deep anxiety because they just can't do it, and it becomes this huge fear. So there's a lot of behavioral cognitive techniques that deal with that underlying fear, that really try to make sense of that for the patient, allow them to be calm. But that is also, in addition to that, there are these various additive things that are all helpful once used in combination. Things like sleep hygiene, just very simple reminders like the fact that you shouldn't be taking caffeinated beverages anytime within at least 4 or 5 hours before going to bed. At least, I would say probably 6 or more for people that have problems. Alcoholic beverages, to avoid alcohol. People always have this notion that alcohol helps sleep, but we know clearly that it actually causes sleep disruption and fragmented sleep, so avoiding alcohol. Having good practices, using your bed and your area of sleep just for sleep and nothing else. Avoiding medications that could be stimulating. Those are called sleep hygiene techniques that are very important. There's another entity called stimulus control therapy, which is really of taking out those external stimuli that impede sleep. So again, the bedroom, only using that for sleep is critical. So making sure that people go to bed when they are actually about to sleep, and not using the bed to play on their iPads or their high-tech devices. using the bed for sleep, changing that environment where all that's done is really sleep. That is very, very important. Another component is called sleep restriction. One of the things that's very effective as well is when you see, based on sleep logs or sleep diaries that we talked about, that patients are spending a tremendous amount of time in bed, so they have a increased sleep latency. It takes them longer to fall asleep. They're sitting in bed. What we can do is actually tell them to go to bed later and limit the time they have in bed. So by limiting the amount in bed and the time to sleep, you increase the homeostatic drive to sleep. So that can be helpful as well. And there's certainly a number of other things you can do, such as relaxation therapies. And these programs are programs that are really formal through different sleep centers where they work with patients on relaxation techniques, biofeedback to really calm their nerves and help sleep. So all of these put together actually work better than any pharmacological therapy. And even if you are using pharmacological therapy, which often is necessary, you very often need to do this in conjunction to pharmacological therapy, and certainly have tried these behavioral techniques as well.
And then you mentioned the pharmacological therapy then. In this case, Dr. Murray said he was using benzodiazepines and propofol to treat insomnia. So I want to ask you about the pharmacological approach. And in your review, let me ask you, in your review of Dr. Murray's statement to the police, did you see any indication that a behavioral approach was attempted?
No, I didn't see anything. There was actually no documentation of any of the medical care that Mr. Jackson received.
Going then to the pharmacological approach, is it fair to say there are classes of drugs that have actually received FDA approval for the treatment and management of insomnia?
That's correct. There are really 8 kind of standard agents that are FDA approved for management of insomnia. These include 7 of them belong to the large group of drugs called benzodiazepine receptor agonists, and amongst those, 4 of these drugs are actual benzodiazepines, and 3 of them are non-benzodiazepines. The non-benzodiazepines are traditionally the drugs that are recommended as first line for pharmacological management of insomnia because they have less addictive properties, they have less side effects, they tend to have a less of a significant negative impact on the quality of sleep and sleep architecture. And these are drugs like Ambien or Sonata or Lunesta. So these are the non-benzodiazepine receptor agonists that they're called. And finally, one of the more newer drugs are the what we call the melatonin receptor agonists. Remember, we talked about circadian clock in the brain that tells us when to sleep and that cycle of sleep. The melatonin receptor agonist, Rosarum, is another drug that is FDA approved for treatment of insomnia, and certainly can also be used chronically because it also has less of a risk for addiction in patients with insomnia.
And as far as benzodiazepines then, and as far as benzodiazepines that have FDA approval for the treatment of insomnia, what are those agents?
Well, they are triazolam, temazepam, flurazepam. So basically just Restoril, Halcyon, Prosom, and flurazepam.
There's 4 total?
Four drugs that are FDA approved. Now, the reality is that other benzodiazepines are occasionally used for treatment of insomnia in the oral versions. However, they're usually addressing an underlying problem. For example, an underlying psychiatric issue like anxiety. for only short periods of time. The real goal is to use the least amount of medication that is effective as possible, and to try to titrate that off, to try to gradually take patients off as soon as possible without risking withdrawal from the drug.
And in regard to the FDA approval, the benzodiazepines that are approved, they're all in the oral form, like a tablet,
That's correct.
not intravenous administration? Correct?
Yes.
Now, you're aware that in this case, Dr. Murray was administering Valium or diazepam? Yes?
That's correct, yes.
As well as lorazepam and midazolam?
Yes.
Specifically on those three benzodiazepines, and let's talk about first lorazepam and midazolam as an intravenous administration. Is that appropriate long-term care for insomnia?
No, absolutely. It's not. It really has no role for long-term management of insomnia.
And how about the Valium or diazepam, oral?
It really, the only times that those are used are if you're dealing with some underlying secondary cause for the insomnia, such as like an anxiety disorder. But really for primary insomnia, meaning once you've ruled out everything, that is not an appropriate management.
And again, for primary insomnia, once you've ruled out everything else, if you did take the time to rule out everything else, how about oral form of lorazepam? Can that be used on a short-term basis?
It can be used for a short-term basis, again, for patients that have some underlying secondary reasons like underlying psychiatric issues like anxiety. It can be used, but the problem there is with that drug is very highly addictive, and use beyond 3 to 4 weeks can really have an addictive nature to it, and it may be very difficult to really get patients off.
You're specifically talking about lorazepam?
Particularly, yeah.
It's a highly addictive drug?
That's correct. I mean, benzodiazepines in general are, and that's why I mentioned in general that our first line of therapy are the benzodiazepine receptor agonists, those drugs that I mentioned, the three earlier.
Thank you. And then in this instance, Dr. Murray's own admissions that he was administering both midazolam and lorazepam in conjunction, of course, with diazepam and propofol, but the lorazepam and midazolam by intravenous administration. You characterize that as an extreme deviation from the standard of care, correct?
Right, for the treatment of insomnia, absolutely it is, yeah.
And particularly in the way he was doing it via IV
IV
administration.
route, absolutely.
Let's talk about then, you've talked about the benzodiazepines that Dr. Murray was using. Let's talk about your findings in regard to using propofol, specifically propofol for the treatment of insomnia. Is that in any way accepted or appropriate?
No, it really has no role for the inpatient or outpatient management of insomnia. There's really it's really inconceivable to use this drug for that purpose. It utterly has no role in the management of insomnia.
You indicated that's regardless of the setting.
That's correct.
And in your findings, you state that the mere thought of considering propofol as a treatment option for insomnia is beyond comprehension. It is frankly disturbing. Why did you make that statement?
I think if you just step back and just look at this for what it is, and if you're just saying that here you have someone that you're diagnosing with really bad insomnia, particularly understanding that there are major secondary causes, and to be treating them with a potent anesthetic that has no proven role in management of insomnia is just really hard to really grasp. It's inconceivable.
And you state unethical.
That's correct.
And why is that?
Because there's just really kind of beyond a departure of standard of care. I mean, it's something that we would never even fathom doing. Really, any reasonable person managing someone with insomnia to be using propofol for that is really, there's really no reason for that.
You concluded that Dr. Murray acted with gross negligence and with an extreme departure from the standard of care, and that through his acts and omissions, he caused Michael Jackson's death. Is that accurate?
That's correct.
You state that additionally, although not supported by the evidence, if one assumes Mr. Jackson self-administered after being given high doses of benzodiazepines and propofol, Conrad Murray is still responsible for creating the life-endangering situation, failing to monitor, failing to have the basic equipment, abandoning his patient, allowing access to drugs, lying to medical personnel, and delaying in calling 911. In either scenario, Conrad Murray played a direct role in causing Michael Jackson's death. Those are your findings?
That's correct.
And would you agree that even under a scenario put forth by the defense that Michael Jackson self-administered either lorazepam or propofol after being given the drugs by Conrad Murray in this setting, that the risk of that happening would be a foreseeable thing that a competent doctor should have been aware of?
Oh, absolutely. I mean, here you have a patient that potentially may have substance abuse problems, or clearly it sounds like he had substance abuse problems, and you're providing this environment where drugs are readily available. They're not locked up there at an arm's reach. That is definitely a foreseeable complication. When you have potent drugs, which in combination, as we talked about, can synergistically have such profound effects that we've discussed at length, that is very foreseeable.
And would you agree in a broader sense that when administering benzodiazepines and propofol, even a 25 milligram administration of propofol in this setting, that the risk of respiratory depression and cardiovascular failure is, again, a foreseeable risk that any competent doctor must know about?
I think this goes to the fact that there were many issues that together culminated in this. The underlying dehydration, his underlying condition, the synergy, the combination of those medications, the benzodiazepines and the propofol, absolutely, and that was something that was definitely a possibility.
And would you agree that respiratory and cardiovascular complications is a known and foreseeable and normal risk when you're administering benzodiazepines and propofol?
That's correct.
Thank you, Doctor. Nothing further, Your Honor.
Thank you, Mr. Walgan. May I see counsel, please? Break a little bit earlier today before we begin with the cross-examination of Dr. Kamangar. And Dr. Kamangar, rather than keep you waiting out here while I do my thing, I'm going to excuse you and remind you that you're not to discuss your testimony or the facts of the case with any other witness until the trial is over. I'm going to ask that you join us tomorrow at 8:45 a.m. Thank you. You can step down, sir. You're excused for the rest of the day. Thank you. You want to take your binder, please? Thank you. All right, ladies and gentlemen, before I provide you with the all-important adjournment instructions, I want to let you know that because of scheduling-related issues, we are not going to require your presence on Friday. I mentioned to you at the beginning of the trial that oftentimes there are scheduling issues, and this Friday is one of them. Both parties in this case, both the people and the defense, have requested that we not be in session on Friday because of witness scheduling issues from the standpoint of both sides, and I've indicated to them that that request is entirely reasonable. I hope you have things to do on Friday, now that you know you have the day off. You don't get the all-important $15 of juror pay, which is an insult, and I apologize for it. But if you want to go to work, by all means go to work. If you have other business or professional-related obligations, undertake them. If you have personal obligations, by all means undertake them as well. I just became aware of this, or I would have let you know a little bit earlier. So your services will not be required on Friday. However, your services will be required tomorrow, so please do visit us tomorrow. I am going to be delivering to you these all-important admonitions. Please do not discuss this case among yourselves or with anyone else, or form or express any opinions about the case until it is submitted finally to you. Do not visit any scene or location that may have been referenced, mentioned, or involved in this case. Don't perform any experiments, or on your own or through another person, conduct any independent investigation of the facts, the law, persons, topics, or subjects mentioned or involved in the case. Don't access, view, listen to, or otherwise observe any television or radio programs, newspaper or magazine articles, or books related to any of these topics, subjects, or persons. Do not, on your own or through another person, access any internet website regarding any topics or subjects or persons mentioned or involved in the case, including but not limited to any search engine sites such as Google, Ask, or Bing, or social networking sites, including but not limited to Facebook or MySpace, or access or post any texts or tweets, access any blogs, or post any messages on any site regarding any topics, subjects, or persons mentioned or involved in the case. Please have no contact or communication whatsoever with the defendant, the attorneys, the witnesses, or the spectators. If someone approaches you or otherwise tries to engage in communication with you regarding any topics or subjects or persons mentioned or involved in the case, immediately end that conversation or communication and immediately advise us. These are very, very important instructions, and I certainly expect that you will follow completely these instructions and admonishments, and that includes the written admonishments, and you each have a copy of those admonitions. Do all of you continue to assure and promise us that you will follow all of these instructions? All indicating the affirmative. All right, ladies and gentlemen, we're going to ask that you join us at 8:45 tomorrow morning. Again, please come tomorrow, but please don't come on Friday, and we'll be with you in just a few minutes. Have a good night. We're recessed. Thank you.